Hello to those of you who are logging in to join us today. I just want to let you know that we're here and we're ready, and we will start in about 2 minutes. Well, okay, that's probably a little less than 2 minutes, but it is 8 a.m. my time here in Florida, and that's what time I was instructed that we were to start. So we're going to go ahead and do that. So welcome, and depending on where you are joining us from today, good morning, good afternoon, good evening, but whatever time it is, I'm just very happy to welcome you and truly appreciate you being here today for our second webinar in the prevention series. I'm Amy Ronshausen. I'm the president of the World Federation Against Drugs, and I have the great honor of being your host today. Let me start by telling you a little bit about WFAD, and then we'll get right to it. WFAD is a multilateral community of non-government organizations and individuals. We share a common concern that illicit drug use is threatening the existence of stable families, communities, and government institutions throughout the world. Our aim is to strengthen prevention, increase access to treatment, and promote recovery. Currently, our membership includes 328 organizations spanning 59 countries, and we are growing every month. This webinar series was developed in partnership with Carlton Hall Consulting, a multifaceted full-service consulting firm designed to provide customized solutions and enable measurable change for communities, organizations, and individuals. Carlton is a dear friend of mine and to the world of prevention, and we are so happy to work with him on this and many other projects. I will start. I see something in the chat, so I'm just making sure it isn't anything that I need to say. Nope. Okay. I'm going to start by introducing all the people who you've logged in to see today. And I'm going to introduce everybody in the keynote and the panel, reading a short version of their impressive bios, and then I will turn it over to our keynote. So the first individual to introduce is our keynote, Giovanna Campello. Giovanna has more than 20 years experience with the United Nations Office on Drugs and Crime in supporting member states and stakeholders at all levels in improving their drug prevention response, applying and contributing to scientific evidence. Most notably in this context, she has led the publication of the International Standards of Drug Use Prevention in 2013 and the UNODC WHO second updated edition in 2018. Since 2016, she has been leading the prevention, treatment, and rehabilitation section of the United Nations Office on Drugs and Crime, thus promoting evidence-based, gender and human rights sensitive practices on drug prevention, treatment, care, and rehabilitation, as well as access to controlled drug and medical purposes. Ms. Campello has a Bachelor's of Science in International Relations from the London School of Economics and Political Science, and a Master's of Arts in Gender and Development from the Institute of Development Studies, the University of Sussex, both in the UK. Now I will introduce our three panelists before we start.
Perhaps you can also change the slide, sorry, Amy, to show the photo.
I had to do two things at once. There's Giovanna. Brian, see, we asked for your pictures and you were probably wondering, they're not even using them. Brian Morales is the Chief of Counter Narcotics Branch for the U.S. Department of State, working within the Bureau of International Narcotics and Law Enforcement Affairs, Office of Global Programs and Policy. As Chief of the Counter Narcotics Branch, he oversees two units, drug demand reduction and drug supply reduction. focused mostly on synthetic drugs. He has worked on the issues of substance use prevention and treatment since 2008, developing and implementing projects with countries in Asia, Africa, and Latin America. Prior to demand reduction, he worked in INL's Office of Afghanistan-Pakistan Affairs, overseeing multilateral counter-narcotic issues for Afghanistan. In other posts at the U.S. Department of State, Brian has covered issues including democratic governance and counterterrorism, and served as the U.S. representative to the Organization of American States, the United Nations Office of Drugs and Crime, the African Union, and other multilateral bodies. Prior to the federal government, he also worked at the Pan American Health Organization. He earned both an MA in Latin American Studies and a BSFS in International Affairs from Georgetown University. Our next panelist, Dr. Goodman Specco, is the Director of International Technology Transfer Center and serves as the head of addiction psychiatry at the University of Cape Town. His work has focused on interventions using non-specialist workers in management of service and mental illness, and he has a developing research portfolio focused on task sharing models for the treatment of harmful substance use, mental health, and HIV. He serves as the director of South Africa HIV Addiction Technology Transfer Center. And lastly, we have our last panelist, Abel Basutu. Abel is a program specialist with intensive experience in policy formation and advocacy, management and implementation of technical cooperation projects in diversified development fields. He started his career as a journalist, trained as an auditor with Ernst Young and chartered accountants, and holds a PhD in business administration. He previously worked for the World Food Program, World Health Organization, and International Labor Organization. He currently works for the African Union Commission as Senior Program Officer of Drug Control. So I will now stop sharing my screen, and I will turn it over to Giovanna for our keynote.
Okay, but you would need to be patient with me for a couple of seconds while I try to share my slides. And Amy, don't go anywhere. I need you to nod to see whether you are seeing my slides. Yes, thank you so much. Well, thank you, Amy, and thank you all for having me and giving me the opportunity to discuss together. I'll be doing a lot of talking, but in reality, I'll be very interested to know what my fellow panelists will contribute, and also your questions and comments. So this will give me the opportunity to, how can I put it, to share with you some successes. We had, some things really worked nicely, and I want to share them because we often, reflect on what doesn't work, but it's also nice to, and important to share some good successes and also some challenges and maybe some ideas to move the field forward. And just to be clear today, I mean, although the section that I have the honor to work for covers prevention, covers treatment, covers access to control medicines, in reality, we work with member states and all of these issues. What I'm gonna work particularly, talk particularly on is the field of promoting the use of science in policy, and specifically the science of drug prevention for the healthy and safe development of children and youth. And I'm saying this on purpose because, of course, prevention is much broader than this. What about the adults? What, are we too old to be the target of prevention? No, of course not. There is a lot that can be done in to assure the well-being and health of people, also in young adulthood and adulthood. But we also know that a lot of what happens also in late adolescence, in adulthood and so on, is maybe not determined is a strong word, but let's say influenced strongly by what happens in childhood. And there is a lot a lot that can be done in childhood to ensure the development of children into healthy adults. And so I've chosen to use this as the field of our discussion, but of course many lessons can be taken and provided to also other fields. And as I was saying, I wanted to share with you a couple of stories of good stories of success, or where we have managed to use science to improve prevention. So for example, this is the case of Uzbekistan and family skills training. So we started working on family skills training before even we published the standards. We started in 2010. But of course, our way of working is always the same, document what works according to science. And you can see this guide that is still relevant to a largest extent on what works in implementing family skills training program for prevention. And then we started working with the member states all around the world to pilot evidence-based family programs to show that they were feasible and effective, and hoping that countries would get interested and in picking up this kind of programs. And the reason why Uzbekistan is a very nice example of how we worked is in fact that when we started, Uzbekistan was very cautious. We entered Central Asia, all of the republics, and we presented our ideas. And at that point, Uzbekistan wrote to us saying, this is interesting, but it's really not for us at this stage. And we said that's okay. And we kept them very much involved. And we started implementation in the other republics. And whenever there was some regional meeting to present the progress and so on, we always invited our Uzbeki counterpart, and that's where they started to get interested. And after a while, when they saw the good result that the training was having on the behavior of children, on the harmony of families, and on the mental health and resilience of the children, they said, we want to join. And they did. And not only they did, but they did successfully. So this graph is one of the examples where we collected data on effects in various countries, including Uzbekistan. It was working, but they got so convinced about the benefits that would come from implementing these programs that they decided to go to scale, and they decided to go to scale on their own. So they really took our pilot, and something happened that's what we wanted, that the country grew so interested and convinced of the benefit that they took over the implementation and the dissemination at country level. And at the moment, every year, the Uzbekistan still reports to us that they reach between 90 and 100,000 children and families every year, and they keep on growing. So for us, this is a very good example and of how showing in an inclusive and respectful manner, of course, taking into account cultural adaptation, because this is what we did in Uzbekistan. But, piloting evidence-based prevention can work, because you can get people interested in bringing them to scale for the benefit of a larger number of children and youth. So this was one way in which we managed to work, and that was very successful, I believe. And shortly after we started working on family, that's where we started working on our standards. Amy already mentioned that we published the first edition of the standards in 2013. And really the standards, here you see both the treatment and the prevention standards, but I'm talking about the prevention standards in particular. So the standards were really a summary of what works and what does not work in prevention, and what does according to the science. And one of the reasons why we wanted to do this was to precisely go to countries and enter into a dialogue and say, look, you're doing a lot on prevention, and can we build on that by adding or moving to prevention policies that have been shown by scientific evidence to actually work? And here I want to bring you the example of Nigeria. Nigeria, a few years back, we had a great opportunity, a program supported by the European Union to do many things, including prevention. And I still remember the call from our program officer in the country office of Nigeria, and she said, so I've been meeting the government on prevention. They would like to start printing leaflets on the dangers of drugs and distribute them in schools, maybe have some seminars. I'm not so convinced about that. What do you think? Well, I said, you are right not to be so convinced. I mean, we know from the science, we know from the standards that information is very important because it impacts the perception of risks. But information only is not enough. And that you really want to invest on building the personal and social skills of children, either directly or through their families. So we said, let's meet. And by then we had a good how can I put it, the skeleton of a good seminar that was based on the standards. And we would basically sit with policymakers for 3 days and say, okay, look, this is what works according to science. Let's look at what is going on in your country. Great. How can we improve it? And we did this in Nigeria, and I have framed the email from our program officer in Nigeria after the training, because she told me this was great. The work plan that you helped them develop on the basis of the standards are extremely useful. We have decided to implement an evidence-based program in schools and an evidence-based program in families. Thank you again. P.S. No mention of leaflets anywhere. And so I was so happy because this laid the work for the graphs that you see in front of us. They adapted and implemented Unplugged, which is an evidence-based program from Europe for 12 to 14 years old. And you can see here how, compared to the control, the prevalence went down, and we were really impacting on the preventing the use and the initiation of use among thousands, because Nigeria is huge, thousands of students in the country. So this is, I hope, is a nice example of how you can use the standards, and we are very much at your disposal to help you to enter into a dialogue with policymakers and try to move them to pilot evidence-based practice instead of things that have not been shown to be effective. Which leads me to another great success, which is, I gave you 2 examples from what I have been doing through the UNODC, but this is something that is being led by the colleagues in Colombo Plan with the support of INL and by the colleagues in Europe. So what they have done is to take the standards and really transform them into a basic curriculum for people that work in prevention, the universal prevention curriculum, to give that basis of common understanding of what prevention science means and what does it mean to really implement prevention according to science. The UPC, the Universal Prevention Curriculum, is extremely extensive, and the colleagues in Europe have created a leaner version that is very much attuned to the sensitivities of Europe, and they are both the colleagues in the Europe and in the Colombo Plan are really busy using this to professionalize almost create a new profession, the profession of preventologist, but really to start creating that idea that if you want to do prevention, you need to learn. There is a competence to prevention, there is a science to prevention. And that will also help us address, and I've seen it happening, address the issue to a certain extent of turnover. You know, this is a common challenge. Politicians come and go. The politicians have different priorities, different ideologies. They want visible and short-term outcomes. And often this is where science goes because prevention based on science is a bit slower. And also there is not that much variety to accommodate all of the new ideology of politicians, right? But if you train, look here, the specialist advisors to the politician, if you train the program managers, then you create that core of understanding in a country that really can help package science for the new politicians and ensure that practice stays anchored in science and in effectiveness. Of course, you also need to train the people who actually deliver the prevention, right? And sometimes this could be, you know, have a profession of their own or even be lay people. But there has been a very, very interesting study supported by Colombo Plan in Peru that has shown that if you train people to deliver a school-based program, and if you train people to deliver the same school-based program, and you give them that basis of universal prevention curriculum, it's more effective. So that common basis of understanding that science is important, that there is a science to prevention and how to put it in practice can really lead to more effectiveness, to lead to more change in the countries, and hopefully also shelter prevention and prevention science from some of the more short-term changes that are due to political turnover. So these are all great opportunities, and I will only add a small nice thing that to acknowledge also your work in advocacy at the international level. Ever since we published the standards, we really started a campaign to disseminate among all of the member states the importance of prevention and of evidence-based prevention. And here you can see plotted the number of resolutions in the Commission on Narcotic Drugs that mention prevention, the number of operational paragraphs that mention prevention, and the number that mention evidence-based prevention. And you can see we published the standards in 2013, and you can see a spike of interest on prevention, and even an increase in the number of operational paragraphs that mention evidence-based prevention. So your advocacy, our advocacy altogether for evidence-based prevention is translating in commitments by all of the member states of the United Nations to do more evidence-based prevention. They've committed to it. Let's take them up to task and let's use that commitment. Okay. So these are all great things. Of course, there are some challenges, but also some ideas for the way forward. So that's what I want to talk about for the rest of the time. How am I doing with times? What? Where am I? One of the challenge is, of course, coverage. Now, you know that the coverage of treatment is very low. Only 1 in 8 people with drug use disorders have access to treatment. And this masks terrible regional differences. Also, we don't know anything about the quality of the treatment. We're only talking coverage. But the fact of the matter is that at least for treatment, we have that number. For prevention, we don't even have that. And there are good reasons for it also, because prevention is much more decentralized, often is covered by many different sectors. So there are reasons why it is more difficult to calculate. But it is true that the coverage of prevention and the coverage of evidence-based prevention is generally low. And look at the graph on the right. That is not a real graph. That is a graph that I have made up, but it shows my perception that of the fact that most of the prevention that is happening in the world is non-evidence-based. And this is where I see an opportunity, because it's true, there is a lack of funding, coverage of prevention is low. But then let's face it, it's also true that there is a lot of funding that is squandered in prevention that is non-evidence-based, that is non-effective. And we could use that power. We could use the power of funding to promote evidence-based prevention. Some countries have already started to use conditional funding, meaning the government will say, of course, we support prevention. Here, communities can apply, provided you, and will get funding, provided you implement evidence-based prevention. Here is the list of evidence-based programs. Here is the international standards on drug use prevention. And I'm looking forward to seeing, I mean, these schemes are working well. I'm looking forward to the point where we would be actually able to evaluate a little bit these kind of schemes and really see that they make a difference. But I think that this is a challenge, but also a place where we have a big opportunity. And then I want to go back to the issue of, to the story of Uzbekistan to highlight another, a bit of a challenge that we have. So I was telling you the nice part of the story. So, you know, Uzbekistan deciding to go to scale and reaching thousands of children and families with the program that had been evaluated to be effective. The question really is, how do we know that what is being implemented among all of these people is actually faithful to the original program? And we know there is a little bit of implementation science that shows that it's one thing to implement a program and in a randomized controlled trial or in a trial that shows the effectiveness. Everything is very controlled, everything is being checked and so on and so forth. It's another thing to go to scale. You immediately lose a fidelity of implementation and you immediately lose the effect, the size of the effect. So here there is an issue that we have as a field, we're still not so equipped to address, even when we have, you know, introduced evidence-based prevention in a country, in a pilot. How do we ensure that when we go to scale, we keep that effectiveness? That is a huge question. And there are some ideas there, but it's something that we will need to work more on. I was telling you that this graph is invented. I am working very, very hard to make sure that this graph is not invented anymore, to be able to give you some data about how much of prevention worldwide is actually in line with the standards or not. We have just started to develop a tool to assess how much national prevention systems are in line with the international standards. I've called it Review of Prevention Systems, REPS, not very imaginative, I know, I'm sorry, but it's easy to say. And above all, I think that that is a project that is going to go on for quite a while, but I hope it will put us in the situation to say, look, the situation is this. This is not invented anymore. It is true that we are doing a lot of good, but a lot is still not evidence-based. Let's make it better. Another potential challenge, opportunity, everything in one that I see is the digital world. And there are many aspects to this. So, of course, the digital world can mean using digital technology to train service providers. And the pandemic has compelled us and accelerated to these kind of processes. The Universal Prevention Curriculum is making an enormous effort to go online. We have been training on family skills remotely, even in very difficult places like refugee camps and so on. So it is possible. We need to study the effectiveness more, of course, but there is some extreme potential there to reach many and to create and increase the competence of many, many more people worldwide. And similarly with the issue of actually providing services. So this super, super cute baby that you see in the on the slide is a baby whose parents live in a refugee camp in Jordan, and they are using, and the parents are using an app that is to remind them of when the baby will need to go for vaccinations. And we have partnered with this app to also provide parents with very simple parenting skills tips to take care of themselves, their families, and the baby. And this is just one small example of the many that are going on in this field, and that we will need to really look into very seriously. This field is potentially, can help us deliver services in very remote areas at much lower cost. What we will need to check is that the effect sizes remain the same. What we will need to check is to make sure that the confidentiality and the ownership of the data remains protected. And of course, we will need to take care that we are not widening, but we are narrowing the digital device. A very, very exciting field. And the last one is a field that makes me feel very, very old, and it is the field of social networks. And I have taken here a random picture of 3 girls on TikTok to exemplify this. Now, social networks have an enormous influence on the development of children and youth. And we are starting to document it's not necessarily positive. In fact, it can be, to the contrary, have a very serious effect on their mental health. At the same time, the influence is there and is strong. I've been watching the Star Wars films with my daughter recently, so I can say the power of the Force is very strong with the social network. We need to use it. And that's where it's really, my appeal is for collective wisdom, because research moves slowly. Social networks move at vertiginous speed. We need to try and learn from each other as much as possible, document as much as possible, so that we don't cause harm. But we really try and use this for the healthy development of children and youth to the extent possible. It's a field that is incredibly powerful, very difficult to tackle, and I hope we can really do something together there. In the interest of time, I will take this last point a bit more quickly. I think that we have a challenge and opportunity in being extremely proactive as we emerge from the pandemic, and really proactive in pushing for the development of services that help the development of children and youth. What we have seen during the pandemic is reports of increased violence and tensions in families, particularly linked to when the children could not go to school and had lost that protection from the school, were closed in the families, and particularly linked to where families lost their income. So of course, this is completely exacerbated by existing inequalities that have been even widening. So we need to work very, very strong. I will go here to link to first of all push for basic services. You see them, I put them here. They are small, but they are small in this picture, but I should make them really bigger, because these are the basic services that protect the health, the safe and health development of youth: schools, extracurricular activities, services for families, outreach to at-risk youth. And on this, we need to push for strong programs and practices that are more linked to the ones that you find in the standards, particularly helping children develop their personal and social skills and resilience by any means possible, helping families cope with stressful situation in a positive way. And now I would add very strongly start strengthening basic mental health services for children and youth. This is something that was added in the second edition of the standards, and I think we should work on this more. And if we do this, we know that we can achieve so much more than substance use disorder only, right? We can achieve more mental health, better academic achievement, less violence and crime, less child maltreatment. And this means that being proactive will mean linking to other sectors, internationally, nationally, and locally, linking to the health sector, and not stay closed in our silos of drug prevention, but really looking at prevention of all addictive behaviors, on promotion of mental health. I'm going wider and wider, and contributing to tackling non-communicable diseases. This is more on the health and development side. But then on the safety and security side, linked to preventing crime, violence, and child maltreatment, all that we do is relevant. We need to join forces. And we need to join forces because, remember, this is what we are here for. We are here to support the healthy and safe development of children and youth, to prevent drug use and other risky behavior. And I know that we can do so much more if we move to evidence and we join forces together. So I will leave it at that, and just thank you once more for giving me all of this space to share my ideas with you. Looking forward to hearing yours. Thank you.
Thank you so much, Giovanna. I was ready to insert myself and say you had a few minutes left, but as always, you were perfect and ended just on time and with enough time to answer some of the questions that we did receive. So the first one is, in the alcohol and drug prevention sector, which evidence-based methods or tools do you consider to be the most successful for girls and young women?
Mm-hmm. Do you want to take a few? Because if I need, I tend to talk a lot, and if I start talking about the first one, then okay. I will take notes. So the first one is about prevention of girls and women. Excellent question.
Okay, and then the next one kind of is the same thing, but for programs that target elderly people. The next one says, can you see in the design of methods, tools for drug prevention that the Convention on the Elimination of All Forms of Violence Against Women has been implemented to strengthen the health indicators for girls and young women in particular? Mm-hmm. And then the last question is, based on the data available to you, which school-based prevention programs have been most effective and successful in West Africa state, and are the key drivers of such success?
Okay, So I'll take, it's great to have a lot of questions with regard to girls and women, and thank you for this. So let's say if the evidence on prevention is this is prevention, okay? And then this is the evidence of what works. The evidence of what works for girls and women is like this. We did a study in 2016 and we wrote to all of the evidence-based programs, and I kid you not, 5% had disaggregated data. That is a scandal. But anyway, on the basis of this, and on the basis a bit of the understanding of the etiology, so of the risk and protective factors that may make girls and women vulnerable to starting to use drugs, in terms of prevention, really prevention, primary prevention, what seems to work more consistently, so is most successful for both boys and girls, is family skills work, is work with families. Work in schools and in communities have mixed results. So there are many reasons why we promote the idea that in a community or in a country, not to do only one, but also to combine work with schools, work with families, maybe work in the community. But that is one additional reason, because we know that like this, we manage to reach both boys and girls. So that's for that. I cannot comment on the Commission. I certainly know that the Commission has and the convention had very strong mandates with regard to the health of women and girls, but I don't know the specific of maybe achievements that their work has brought. I certainly know that for us, we work under the SDG framework by now. The SDG framework has SDG 3, which is health for all, but has a very strong SDG on gender equality, which is SDG 5. And this is being pushed very strongly, including by the organization, the Is the Custodian of CEDAW, which is UN Women, to be mainstream in all of the work of the organizations. And we certainly do that, both in prevention and in treatment. Where I don't have a good answer is with regard to senior citizens and the elderly. For a variety of reasons, there are a few programs that have been evaluated. I'm being generous. Hardly any. And in terms of prevention, I'm talking about, there is also not so much data. The little data that we have points to the direction that there is a lot of non-medical use of prescription drugs among the elderly, which is natural. And therefore, all of that work that goes around the rational prescription of control medicines and strengthening access for medical use whilst preventing abuse and diversion for non-medical use, all of that, the kind of work that we do with member states would be very relevant there. But I don't have that easy program to direct you to. If the person that has asked the question is really interested in starting something there, I would very welcome to be in touch and think together what can be done in whatever is the context that he or she is working. Yeah, so that's all I have to say.
Perfect, thank you. So we will move toward the panel and build upon what Giovanna has laid out for us. And so we have Brian, Goodman, and Abel. And Brian, I will ask you to go first and just kind of talk a little bit about your role and experiences. And then the question that I posed to each panel member is based on your unique role, experience, and expertise, how would you build upon Giovanna's information, and what proposal can you offer to move the field forward?
Great. Thank you so much, Amy. Thank you to WFAD for this opportunity, and thank you, Giovanna, for her presentation, and greetings to my fellow panelists as well. Thank you so much for being part of this. Greetings also to the audience. Thank you very much for your interest in this conversation. Giovanna's presentation covered many important themes, and I wanted to touch upon some of those and just highlight how they really resonate for me as well. First was the concept that research should inform policy. For me, that's critically important, absolutely. Research, policy, and practice. These are the three pillars or the three major components of any drug demand reduction system. I think we have a lot to be optimistic about, as we heard in Giovanna's presentation. We have 40 to 50 years of prevention science. It's a validated field of science. And despite some particular areas being very rich, like family and school prevention with a lot of research, and others requiring a lot more attention and a lot more research, like media prevention, for example, I think that we have a good body of evidence under our belt, and still a lot that we can look forward to researching and investigating in the coming years. I think it's a beautiful thing when we see that research
So has Brian frozen for the rest of you?
Yes.
Okay. And it looks like he might have been dropped. So while he comes back on, and in the middle of something really good, he kind of left us hanging there. We will move over to Goodman. We'll let you kind of continue on that. And again, the same question, and I'll just quickly repeat it. Based on your unique roles, experience, and expertise, how would you build upon Giovanna's information, and what proposals could you offer to move the field forward?
Amy, I think Brian's back.
Yeah.
Oh.
I'm back on another device. I'm so sorry. I don't know what happened on my government computer. So I'm going to turn. I'm going to turn off my volume over there. Can you all hear me?
Yep, you're good.
Okay, I'm going to reposition here. And sorry for the technical difficulties. Once again, here I go. I'm not sure where I left off, but I was saying that we should be very optimistic. We've got 40 to 50 years of evidence-based practices in prevention under our belt. And it's wonderful to see when research is integrated into practice. That is the design of interventions and programs around the world. And we see shining examples of research translated into policy and into practice, such as the work of UNODC and the work of Giovanna Campello, which really exemplifies excellence in prevention. We can also find excellence in prevention. I'd say in all major regions of the world, we see many wonderful examples of prevention programs that are being introduced around the world. But the problem is, and what I wanted to highlight and emphasize is that these evidence-informed and evidence-based interventions are reaching small numbers of people in their countries. Giovanna mentions a lack of coverage, or I think of also as a lack of dosage. The amount of intervention may be diluted or insufficient over the course of years. The effort is not sustained. We talk about not having a sprinkling of some prevention programs for a small segment of a population, but really you want to consistently deliver these interventions year after year, so that really the formation and the integration of these interventions with youth follow them throughout all of childhood. And if we zoom out and look at the big picture, I see a major challenge ahead of us. I see that there's also a disconnect around the world between policy and practice, and not just in the field of prevention, also in the field of treatment as well. But in the field of prevention, on one side, we have the beacons of enlightenment, right? We've got researchers, we've got prevention scientists, universities, academics. They're speaking the language of environmental design and systems analysis. This sector is small but mighty, dedicated, although under-resourced. On the other side, we have a second group, the committed implementers, the advocates who come from many professions, so many professions that they're only common defining characteristic is their advocacy and passion to build protective factors and minimize risk factors amongst youth. We have parents, teachers, counselors, we've got faith-based leaders, law enforcement officers, civic leaders, journalists, human resource managers, and of course, youth. And that's just the tip of the iceberg. I would dare to call them the silent majority. Many in the second group are non-professionals. Few of these are implementers. Few of these implementers are researchers. And I should say conversely, that many researchers are implementers, but a few of the implementers are actually researchers. The vast workforce is not really professionalized or trained. So our challenge today is that we've got many well-intentioned implementers, but they often lack access to that research. And the solution that we proposed in the State Department some years ago was to bring these two groups closer together, to help translate science to practice through manualized curriculum. And as Giovanna was mentioning, and as you may have heard Dr. Zili Sloboda, who presented in the first panel of this conference, we pulled together these researchers and supported them to develop the Universal Prevention Curriculum, which has now been translated and disseminated in dozens of languages and countries, including the European adaptation, the UPC Adapt version. Now, we could have developed this training in a couple of ways. One, we could have created a directory of evidence-based programs through this curriculum that are in the public domain and trained these interventions, very similar to the database that the US government had, the NREP database some years back, which is a directory, a listing of evidence-based programs. We took a second option, which was instead to focus on the research and train what practices are in line with the evidence. We chose this modality because we seek not to build a directory of evidence-based programs, but to engage the existing ill-defined workforce, to train them, to cultivate their knowledge and skills. We can't afford to turn away any volunteers to reach the economies of scale necessary to have a transformational approach on the prevention system at the macro level. And I will caveat that by saying that in this vast workforce that I'm calling in large part unprofessionalized, you do have very professional sectors as well. So it's not to discount the work of those that are prevention scientists or those that are researchers or those that have really internalized a lot of that research. But I'm saying that it's not enough, that to reach those large numbers, we need to go beyond that. And so I'd like to put forward a goal for the next 5 to 10 years that we're looking at the State Department. First, it's critically important to map the existing prevention organizations engaged in the prevention field and train them in strengthening whatever interventions they are implementing. Of course, we should also train prevention workers in environmental prevention, policy design, to ensure that policy, practice, and research support each other in a systems design. Second, I feel that we should develop a universal quality assurance standard in the field of prevention. What features should any prevention organization demonstrate to be considered a quality prevention provider? Finally, I feel that we should develop a universal accreditation process where national accreditation agencies are supported to evaluate and accredit organizations in their countries based on the single universal quality standard. The global accreditation system would set an international benchmark, and organizations engaged in prevention activities, whether government or private sector, would have a point of reference against which to measure their progress. Today, this is what we're doing in the treatment field with the UNODC WHO Quality Assurance Program and the efforts of other international organizations. And tomorrow, I'm confident that we'll do the same in the prevention field, because any field of science has a certain amount of universality that can be referenced to develop quality universal standards and bring coherence and cohesion to the field. Thank you all very much.
Thank you, Brian. I took a lot of notes, a lot of good stuff that you said there. And we do have some questions that came in, but we are going to let each panelist speak first and then kind of collate all the questions that came in, and we'll ask those at the end. So I will go ahead and turn it over to you, Goodman.
Thank you so much, Amy. I'm going to be a politician and answer your question the long way, but I hope you'll get what you're looking for at the end. And it's a tough act to follow, Brian and Giovanna, so wish me luck. So my background, as mentioned by Amy in introduction, is I'm head of a Division of Addiction Psychiatry at University of Cape Town, where we focus on undergraduate and postgraduate teaching at the Faculty of Health Sciences at University of Cape Town. And that also is where the South Africa International Technology Transfer Center is located. So I am director of the South Africa ITTC, which is funded by Department of State INL. So Brian is my direct boss, so no pressure at all. So the ITTC thus far has been focused on capacity building for multiple levels of CADRA within the substance treatment field. We've also focused on technical assistance for the development and implementation of policy at provincial level, at national level. Our focus has largely been on screening, brief intervention, and referral to treatment, along with a few other packages. And this has included now a tool which we've co-developed with some colleagues at University of KwaZulu-Natal, community detection, using a tool that we've just collaborated on. So that tool provides for both detection as well as psychoeducation and some sort of early sort of preventive engagements. And so we're looking forward to piloting that tool and publishing on it very soon so that we can share with this community for your feedback. So the ITTC thus far, beyond these activities, hasn't really been as active in the prevention space as we'd like to be. And we've realized in recent engagements, this is a key area. And so we look forward to moving more strongly into this. We work quite closely with the African Union. And so we are guided by some of the provisions of the African Union. So the African Union Plan of Action for Drug Control and Crime Prevention, as I'm sure Dr. Abel will speak to in a moment, outlines some key activities to support prevention of drug use, with a particular recommendation that all these activities, again, I'm sure aligned with the UNODC documents, that these must be evidence-based and sort of focused on establishing focal units for drug use prevention, focusing on multi-sectoral engagement, which I think we can all agree is absolutely essential to achieving anything in prevention, focusing on awareness campaigns, but which are more focused, Giovanna, and not just handing out pamphlets, driving debates which are focused, and other engaging, co-constructed and co-developed age-appropriate activities across the spectrum from school and beyond. As well as exploiting social media. I mean, we can see now what's happening with COVID and vaccines, that social media is such a driver of behaviors and outcomes in public health. So I think the impetus to exploit social media and to learn how to do so effectively is really gaining momentum. And of course, to then continue to make use of traditional media and entertainment industry. And then to engage broadly in the provision of training in family and parental skills approaches. AU also speaks about the dissemination of visual aids supporting basic coping and parenting skills, but again, in a focused manner, which is responsive. And of course, exchanging of best practice between AU member states, which is a challenge in any group of, in any collection of member states, but certainly it's something we look forward to assisting the AU with. In South Africa, as part of Africa, the management of substance use disorders is governed by a few pieces of legislation, the most important and relevant of which is the National Drug Master Plan 2019 to 2024, which is provisioned by the Prevention of and Treatment of Substance Abuse Act number 70 of 2008. So what this act does, or what this master plan does, it provides for a tiered structure of collaboration from municipal to national level for addressing substance use disorders, and provides for specific guidance for interdepartmental and intersectoral collaboration in drug demand reduction, following a few key principles. These principles are that interventions must be rights-based, so it must protect and promote human rights. It must be evidence-based, which is the main thing that we hear about today. It has to include multi-sectoral and multilateral approaches and engagements. It must be people-centered, as was the key focus of our recent Addiction 2021 conference, and must be inclusive and participatory to ensure success and longevity and buy-in, as well as uptake in general. So this outlines really the guidance for the provision of universal, selective, and indicated prevention strategies. So in terms of the ITTC, we work with the whole country at national and provincial level, but we have two main provincial partners, KwaZulu-Natal Department of Health, as well as the Western Cape Department of Health. In terms of the KwaZulu-Natal Department of Health, what have they been doing in terms of prevention? So they've focused on creation of safe and protective environments by decreasing the availability and accessibility of commonly abused substances. They've worked on interventions aiming to decrease the desirability of substance use. They've used champions to speak out against substance misuse and informing folks about substances which are most risky, in line with what's most problematic in the province right now, including cannabis and wunga. And of course, for the country, alcohol is a major challenge. They've also adopted strategies around provision of information, where they've used co-created multimedia campaigns targeting youth. They've used countertop advertising that's intended to counteract the advertising messaging, how cool it is to drink, how cool it is to use substances. They've used education of social structures to prevent initiation of substance use. And of course, then also included some curricula at school level to increase awareness and knowledge. They have also included skills building counseling, as well as strengthening of collaborations between departments of health and social development and other non-governmental sectors. The Western Cape Department of Health has recently published a report outlining the activities from April 2020 to March 2021. Keeping in mind, just for reference, our population in the Western Cape is about 7 million folks. So they've seen the largest number of service users accessing early intervention services. That's about 4,320 folks, which is much greater than other folks who've been accessed for provision of treatment. So it seems like folks are actually taking this up, and I think the rest of the numbers will indicate that. So some of the programs worth noting that the Western Cape has focused on are the Strengthening Families program, which most of these are collaborations between City of Cape Town, Department of Social Development, and Early Childhood. So the Strengthening Families program has in the past year reached 150 families through 15 instances of the rollout of this program, which is fantastic. Another program, Essentially Me, which really promotes the enhancement of protective factors within learners, has reached 705 learners in the past year through 47 implementations. The Fetal Alcohol Syndrome Simulator program, which similarly is meant to strengthen protective factors within learners, has reached 585 learners in the past year, even with the challenges of COVID, where they've had to use a hybrid approach to achieve those numbers. After schools program, which are meant to support substance use prevention, including sports and recreation, arts and culture, academic and life skills programs, have been provided at 41 sites across the province and have accessed more than 4,000 learners and approximately 160 after school practitioners in the past year. So in terms of additional distribution of information, they've distributed in this province substance abuse related books to improve knowledge as a collaboration between City of Cape Town and the library and information services. And they've used various other awareness campaigns with excellent reach, such as the Fetal Alcohol Syndrome Awareness social media campaign, which has reached nearly 4 million folks. So there's additional numbers which I could demonstrate really the effective reach of those programs. So exciting progress there. So to finally answer your question, Amy, what is my proposal for the move to really move things forward, but in terms of the mandate that ITTC has, so what's needed to move us forward? So as Brian mentioned, it's really, and I think this is something that we've been talking about, Dr. Abel and my colleagues from the department who I've seen on the attendance list, is to really map comprehensively the prevention efforts. I think the Western Cape has done really well to map clearly what has been done when and how it's been effective, so the metrics are clear, at least in reach. One of the challenges we have is around the quality assurance piece. So what are our what are our indicators? And that's part of the challenge. So we have to develop those indicators, develop a common language for quality assurance. So it's about mapping that for other provinces as well and across the country, and then establishing where the gaps lie, establishing what is the extent of evidence basis for these interventions. And this then links to then collaboratively developing those indicators. And something Giovanna and I discussed yesterday is, in order to effectively establish buy-in for these indicators, as many stakeholders need to be at the table when these are fashioned, and so that you try to meet as many folks' needs as possible, with the main outcome being that public health outcome. In order to move us forward, there needs to be support for research and support for development and buy-in for M&E processes, and to provide for intersectoral collaboration. As I mentioned, the National Drug Master Plan provides for how all of these partners need to contribute and what their specific roles can potentially be. The issue again is that silo effect. A lot of folks then have to sit down and tick their boxes, so there isn't much room for figuring out how best to collaborate. And that's part of what ITTC is here for as the grand conveners, as it were. Of course, the capacity building is essential, and we're excited that UPC is now available. Provincial partners have specifically said to me that they are looking for curricula in prevention. So we're excited to, in collaboration with the Colombo Plan Drug Advisory Program, to begin looking at how we roll that out and assist for these prevention curricula. In terms of, we were talking about how do you support the intersectorality, is that the right way to say it, between research, implementation, and clinical practice, and teaching in general, capacity building. I think the placement of resources such as the ITTC in faculties such as where we are key in supporting the research and monitoring agenda, as well as capacity building at both undergrad and postgrad level, and to support the advancement in the field. We're happy in South Africa, we've just recently been accredited in terms of addiction psychiatry as a subspecialty. So I think that provides a vehicle for us to pursue funding opportunities to support the development of addiction as a field. So we can then use some of that momentum to support development of prevention as well. So I hope that answers your question, Amy. Thank you.
Yes, thank you. And you said that you were going to answer it as a politician and go the long way around, but usually the politician does not then answer the question. They just, and you did. So you did a very good job, very good job. I will turn it over to Dr. Abel, and then we do have a few questions from our attendees. So we'll do that after we hear from him.
Thanks, Amy. I just want to join fellow panelists in applauding Giovanna for that robust panoramic overview of the prevention landscape. And thanks to Brian and Dr. Goodman for the important pointers. And thanks also, Dr. Goodman, for graciously outlining policy initiatives of the African Union. So reflecting on Giovanna's brilliant presentation, research influence on policy, very, very fundamental. I think the life skills approach in the UNODC's Unplugged prevention program has a positive impact from the reports that we have received from African Union member states, Mauritius, Nigeria, Egypt, Morocco, and Mauritius has involved the private sector to contribute substantially to it, so it comes with a sustainable element to it. And a number of countries have indicated to us their interest in adopting this program. So that's very, very fundamental. Changing the culture of prevention, again, very fundamental. Is prevention considered a separate activity from the mainstream, or is it very much part of everyday life? That's again, something that we have to ponder about. Creating that structure that supports evidence-based practice at system level, the creation of spaces and using existing structures. And here I was thinking, as Giovanna was talking, I was thinking of schools, community centers, and so on. And roughly speaking with prevention practitioners from across the continent, we all agree that we are at a point where we require a paradigm shift in order to shift to evidence-based informed programming, because a lot of what is happening in the prevention field is informed by gut feeling and is rather reactive in nature. So what has worked, as Giovanna was saying there, research, it does help to make a case for prevention for policy and decision makers. And permit me to use Kenya as an example. They did primary and secondary school surveys, which helped to make a case for prevention with the Ministry of Education, and collaboratively developed national school guidelines for basic learning institutions, which were released in July this year. Previously, there was a lot of talk about increased substance use in schools, but very little by way of activities and programs to intervene. And therefore, I think the next step that they are going to do is, of course, implementation. And we'll be looking at Kenya very closely from the African Union. Training, professionalization of people working in prevention is a key element, and Brian and Giovanna alluded to that. So UPC already provides a curriculum for various settings, family, schools, workplace, media, and so on. There are a number of countries, of course, that have initiated capacity building for prevention, especially in Africa. However, translating these to actual programs and activities is an uphill task due to funding gaps. Then we look at supportive government. Firm political will is needed. As I have already alluded to in the case of Kenya, governments have to take ownership of prevention from national level, cascading to local governments at provincial, county, and district levels. And that means, of course, allocation of dedicated resources for prevention or integrating resources in larger programs, for example. What does not work is, as was highlighted, is sporadic, or should I say, standalone activities or events. Awareness creation, which is not linked to any specific programs, those ones do not work. And then, of course, the issue of funding gaps. How do we move the field forward? Just to add on to what other panelists have said, I see perhaps at the African Union and UN levels, the need for constantly engaging in high-level advocacy for prevention, because there is high political leverage in these multilateral organizations. And then, of course, dedicated resources for drug use prevention as a core activity and planning at national level, and roll out decentralized implementation with local authorities as well as civil society as important cogs. And harnessing, of course, the creativity of young people or young influencers, if I may say, supporting them to use social media, which Giovanna alluded to, with well-tailored messages. In brief, those are my reflections, Amy. Thank you.
Thank you so much. We really appreciate those. There was a quick question on if you could provide a link to the document of the findings from Kenya. And if you can't put that in the comment section, then maybe you can send the link to Regina, who could then send it out to the members so that they can review that document as well.
Thank you.
That would be a great resource. Okay. So we did have a few questions come in. So in no particular order, I'm just going to ask the ones as I have them here on my screen. So one of them was, there's so many, I'm looking here. One was kind of, well, let me see here. Maybe Regina, could you send me, I'm have a full screen of them here. One of them was, how do we ensure that the research and policies for prevention are not influenced by the industries of addictive substances? So for example, we know that, they have some predatory practices when it comes to the alcohol industry and the tobacco industry. And now we are seeing that in the cannabis industry as well. And this is to any of the panelists, how can we ensure that research and policies for prevention are not influenced by them, or how can we counteract that influence? Giovanna, you want to take that?
I can try. It's not that I have a ready-made recipe for this one as well, but I think that we have, and particularly, I say we, but what I mean is particularly WHO has a lot of experience in providing guidance and good practices on how to regulate the involvement of tobacco and alcohol industries. And I think that this could be extended to reach to cover any of the other industries. So I think that that's where we need to look at. As a starting point, the standards have a reference to the tobacco and alcohol frameworks that have been agreed to by WHO, and that already indicate very clearly policies that are necessary to protect children and youth. And then if need be, we can go more in depth, but for that, I would need to know more, and then I can put the person more in contact with the colleagues in WHO, either with the tobacco and the alcohol in teams, let's say. But there are some very, very important lessons learned that we can apply from the tobacco and alcohol industries. So, and those are available with WHO.
Great, thank you. Another one that came in for Dr. Goodman, but any of the panelists who could answer as well, is how do we measure the impact of reach? In terms of this question was, as I walk along the lines of leaflet approach, where information is distributed in the hope that it will translate into impact. When we look at social media and things like that, how have the 4 million reached through social media been impacted, for instance?
Yeah, look, that's information I can certainly reach out to Western Cape Department of Social Development to find out. But I think that the benefit of social media and anything electronic is that one is able to provide a landing point beyond the click-through. So, the reach, the initial reach would be the click on the link. And then should there be some activity that folks are then engaged in, one is able to then measure their level of engagement and outcomes of that process. So I think that's where social media differs from leafleting. But I totally understand where that concern is coming from. But for me, that's the benefit. I don't have the data for how Western Cape has measured the impact beyond saying they've reached 4 million folks, but it's something I can certainly follow up with them.
And I think kind of what I've heard some of you discuss is that maybe that reaches the starting point of a conversation. So it's not kind of like what we talked about with the dissemination of information is not the only path, it's the start or in combination with other things. And Giovanna, you want to add to that?
Yeah, so in the conversation that we were having just the other day, and Goodman was also part of it, and in the development of the assessment tool of National Prevention System, that's exactly what we are trying to do. We are trying to develop a tool that would assess the reach, but also the quality of the intervention, so how much they are in line with evidence. And that is still not enough. Already one of the people in the group was saying, yeah, but we still don't know if if a prevention system does everything and it's all according to the science, it still is not automatic that it will have an impact. That will need to be measured. And I said, yes, But as you mentioned, this is the start of a conversation. At the moment, we are not even able to give that reach. So we are not able to say prevention in country A covers 5, 10, 20, 80% of the people that need to be covered. That is not possible. And so we would like to get to that stage and to be able to say of these, so many are covered by evidence or good quality interventions. So many are covered by non-evidence-based intervention. That would already start a conversation on how to improve the systems. It's not easy, and it will take a while. But I think there is a very, very necessary path that we need to go to, because otherwise we are just going in circle. We are not, and we are not improving anything.
Okay, good. This one is to Brian. How do you recommend that the gap between researchers, theorists, and practitioners can be reduced?
Yeah, that's a really good question. I mean, we can think of a short term, right? Which is simply, let's just connect researchers to practitioners. And let's, if we're going to do a project in this country with these partners, let's make sure that there's researchers that are integrated. That's fine at the short term level, but it's not viable for scale, because the universe of researchers is small and the universe of practitioners is immense. And will continue growing and growing, I would suspect, at a faster rate than our universe of researchers. So I think what you really need to do is to build a demand reduction system and architecture that makes these voices and these interactions much more natural and available to grow at scale. And that was, I think, one of the impetuses for establishing the International Society of Substance Use Professionals, or ISUP, where you have different networks with different skill sets that are built into a recurring mechanism of technical assistance, dialogue, connectivity. So yes, researchers are very good at researching, and university professors are good within that universe of didactic training and development of college students. But then we have another universe of trainers and facilitators, which may not be the same skill set as a university professor or a researcher. And so that's another cadre that has to also sort of modulate and interpret and help disseminate with this vast workforce audience, sort of these tools, techniques, interventions, and help apply those through adult learning theories and so forth. And so it's really creating a culture of learning, of professionalization that an organization like ISUP could support. There's a process now of certification as well. Another organization that we work with, the Global Center for Credentialing and Certification. Let's validate now knowledge and skills with certification. So that whole architecture needs to be packaged in a way that the vast workforce can slowly sort of come in contact with that science of a very small group of people. And I've heard from skeptics that we've developed too much curriculum and it's too difficult to digest. The UPC, there's 50 manuals at this stage in the domains of family, school, workplace, environmental prevention, media, monitoring and evaluation curriculum. It's too much for anyone to be able to absorb all of that. But that's sort of the beauty of the prevention field. There's a lot there. There's a lot of richness. And it's going to take, years and years and a lifetime of development to be able to continuously learn and build skills and knowledge. And we should be striving toward that goal of continuous sort of personal development in the prevention field. So I'd say, yes, it's too much material, and that's by design, because it's a real field of science and we need to really dedicate time to this.
Absolutely. Perfect. And this one is to Dr. Abel. What would you say is needed for prevention not to be separated from society and everyday life for the population, but instead being included?
Thank you very much. What I was referring to is if programs are standalone or once or sporadic, then they are not effective. What we need is to infuse them in our daily lives. And here, without necessarily thinking outside the box, I am going to refer to the UNODC Unplugged programs, which have had so much impact. The Family Skills Program, which has also so much impact. But what is needed is sustainability of those programs. Thank you.
Perfect. And then we will do this last question, and we will pose it to whoever in the panel wants to take it. What are some of the methods used in the prevention field that help improve the prevention program if underdeveloped countries, governments don't want to honor and support these prevention programs? So I guess if you can't get that buy-in at the top level, maybe because with evidence-based and evidence-informed, there's a lot that goes into it, and sometimes it's cost prohibitive. What kind of things could we put forth to make that work without that buy-in? Giovanna?
So the thing about the evidence-based is that it sounds scary, but it doesn't have to be. And certainly it is the case that in the past, a lot of evidence-based programs have been developed by universities with a lot of money, and the universities were basically selling them. And, it was not cheap to buy the right to use a program. But I guess I should have put it as one of the good successes that we have had. Slowly, we have been building programs that are in the public domain. And certainly that is the case of the programs that we have built for families, and that are specifically tailored to low resource settings. So that can be delivered with very, very minimal resources. And in reality, just, the willingness of people to be trained and deliver the activities. Also in refugee camps, in population that are displaced, in very, very poor communities all around the world. And we have had that also in our experience. We were in a country, the country was not interested. We said, fine. We started to work low-key with the local civil society organization. We kept on inviting the government until they saw the real good benefits, and they started to get in. That was not a lowest income country, but there are evidence-based practices that are designed to be delivered with really, really on a shoestring, and are still effective. And certainly this is the case for some of our programs with families. And I can help whoever look for more if it's not what they're interested in.
Great, perfect. And I think some of these questions are a great segue into the upcoming webinars that are going to finish out the series. So with all of that, I will put up this last slide and just thank everybody for joining us today. Thank our amazing panel, Giovanna as our keynote, and Brian and Dr. Goodman and Dr. Abel. I feel like I've started my morning off with rock stars in our field, and I'm so happy to have everybody here. And I'm just trying to figure out how to share my screen still. So as we close, I want to remind you of the follow-up webinars that are in the series, and I'm trying to pull that up, but I am a little behind. I was so engrossed in what's
coming. It's coming.
Okay, I was so engrossed in what everybody was saying, I closed out that part of it. So let's see the bottom of it here. So we have coming up on October 5th, Practitioners of Prevention, which kind of just goes into what we were ending this question and answer section with. October 19th, Gender-Based Violence Prevention Approaches, which a lot of the questions were about gender-based approaches. And then the last in our series on November 2nd is the one on marijuana prevention. And no surprise who will be your host for that one. I think that is me again, because I am always the marijuana person. So I look forward to attending all the rest of those with you all and some others and being the host. So you still have time to register for those, and I encourage you to do so. Thank you again to everybody who is here with us today, and to Regina and Cressida and Carlton, who have been behind the scenes making all of this work and keeping us all on time. I look forward to seeing you all at the next webinar and hopefully in person soon. And so until then, stay safe and healthy. And remember our theme that we're trying to put out there, that prevention is better together. So you guys all have a great rest of your day and carry on with the amazing work that you're doing. Thank you so much.
Thank you, Regina. Thank you, Amy. Thank you,
Thank you
Cressida.
all.
Thank you,
Take care.
Carlton. Thank you, panelists.
Thank you everyone so much for being with us today.
Bye, Carlton.
Take care. Bye. Thank